All right, it's really happening now. Let me change the view so we have the speaker view. Hello, everybody. Welcome. It's another webinar season. Happy holidays. Hopefully the weather's doing something for you all. It's really gloomy here in Atlanta, so I'm going to try and power through here and stay positive because I'm really thrilled to be joined by Dr. Dan DeSalvo from Texas Children's Hospital. And Syra is also here. She's going to stay camera on for a little bit. Hi, Syra. How are you?
I'm good.
Good. Syra actually arranged this webinar, so I'm just here to do the fun transitions. Dr. DeSalvo, welcome. Before we get going with my slides, please introduce yourself to our attendees watching live and watching the archive after the fact.
Sure. Yeah. Christopher, thank you so much. It's great to be with you. And Syra, thanks for reaching out. Great to connect with this awesome Tidepool community. Thank you for what you guys do as just sort of shepherds on this journey and ushering in this community and creating this space where people can gather online and share resources and community and build relationships. I think that's truly amazing. So I'm Daniel DeSalvo. Dr. Dan is what my patients call me. So Dan or Daniel. I am a pediatric endocrinologist at Baylor College of Medicine and Texas Children's Hospital in Houston, Texas. And I was just talking to Christopher about Texas Children's. You know, it's a huge campus. We have the medical center campus here in Houston. We have two freestanding children's hospital kind of west of us and north of us in the greater Houston area. And we have kind of a partner campus in San Antonio, and we're going to be building a children's hospital in Austin, Texas as well. So we really are Texas Children's Hospital. And I've been here for now 6.5 years. I did my pediatric endocrine fellowship at Stanford University in the Bay Area, where I had the incredible Dr. Bruce Buckingham as a research mentor, who I learned so much from. I loved my time there, and Texas is home for me. So this was truly a homecoming to come back to Texas, and it's been an amazing 6.5 years professionally and personally for me. In addition to my clinical work as a pediatric endocrinologist, I'm also a clinical researcher working mostly with advanced diabetes technologies like closed loop systems. Have a current project that's focusing on remote patient monitoring in diabetes. It's sort of a recent award that we received, and so we're still building the team for that. And then also working with my colleague, Dr. Marissa Hilliard, who runs our Resilience and Diabetes Lab here at Baylor Texas Children's. We call it the RAD Lab. So really kind of harnessing the incredible strengths and resilience that people with diabetes have to improve not just medical outcomes, but behavioral health outcomes as well. Kind of putting all those pieces together to live well and thrive on their diabetes journey. I also do a lot of sort of volunteering with different groups that I really believe in their mission of helping people thrive on their diabetes journey. So I serve on the T1D Exchange Quality Improvement Collaborative, the College Diabetes Network's Clinical Research Advisory Committee, and also the Beyond Type 1 Scientific Advisory Council. And, you know, with that being said, you know, I definitely want to pause when thinking about Beyond Type 1 and the incredible and unexpected loss of the amazing CEO of that organization, Tom Scher, who tragically passed away just a few days ago. And, you know, he has been one of those just incredible leaders in this community, so much passion and energy, you know, to kind of provide a specific example. You know, just last week, he reached out to me about somebody who kind of lives in the Houston area who had a specific need and was just, you know, he took the time to reach out to me to see if I could kind of connect them with somebody. And that's the kind of person that Tom was. In addition to being an incredible leader and mentor and friend to so many, he took the time to reach out to people in that Beyond Type 1 network, you know, his own personal time to make sure that people were connected. And he just has done such an incredible job in the type 1 diabetes space. And so, you know, if we can all just have a brief moment of silence as we think about Tom.
Very well said, Dr. Dan. We can, again, continue to offer our condolences to Tom's family and the Beyond Type 1, Beyond Type 2 extended family there. Very tragic indeed. There's no clean way to segue from that to talking about diabetes data. So we're just going to take a bite out of that cupcake and have ourselves a conversation on some diabetes data. For those of you in attendance live, thank you for joining us for this conversation. There's a Q&A button at the bottom of your Zoom window. Please use that to ask questions throughout this conversation. I will bring them in gracefully to our conversation. And I have some slides I prepared for you all. Ready? This is how we talk about the Zoom share button. All right. Talking about pediatric case studies with Dr. Dan DeSalvo. He's given us a lovely introduction. Shout out to Texas. Also, Dr. DeSalvo, do you have a cowboy hat? Is that a thing? Are we allowed to ask about that?
I've got cowboy hat. I've got boots. I've got the whole shebang. We have the incredible privilege of hosting the Houston Livestock Show and Rodeo every year. I encourage all the listeners, all the people involved, find out when it is and come attend sometime. It is worth a few days in Houston to spend some time at the Houston Livestock Show and Rodeo. It's an amazing experience. Also,
I feel like I might have offended you by asking if you had a cowboy hat.
No, not at all. I also rode my horse to work today, Christopher. I'm just kidding. I didn't do that.
Okay, this is going to be a great conversation. Anyway, so today I'm providing a brief overview of the Tidepool platform, and then we're going to be talking about some data, actual patient data with Dr. DeSalvo. We have anonymized the names. James Jellyfish will make his glorious return to this webinar space. And then again, throughout, please ask your questions. I will have plenty for Dr. DeSalvo as we go. So as a reminder, Tidepool is a nonprofit organization. So glad you're here. We make diabetes software that integrates data from over 60 blood glucose meters, insulin pumps, and continuous glucose monitors, including the Tandem X2 insulin pump with Control-IQ technology that is currently attached to my hip and letting me know that my blood glucose is very high right now. Uploading all your data requires Tidepool Uploader. This would be installed on your compatible Mac or Windows PC. You'd be using a standard USB cable to upload all of your data. For example, from my Tandem insulin pump, I'd be connecting that same USB cable I use to charge my pump to upload that data to your glorious and free Tidepool account. We're up to version 2.40.0. So if you are keeping score at home, please check to make sure you have the latest version. If you don't, check for your updates. You can always go to tidepool.org/download to get the latest version. After you've uploaded all of that beautiful diabetes data, you'll be viewing it in Tidepool Web. As a key reminder, folks, Google Chrome is required to view your data in Tidepool Web. This works for clinicians as well as the patients at home. Let's have ourselves a quick tour of Tidepool Web, shall we? Ready? It worked. Okay. So when you log in as a clinician, the first thing you'll see is a friendly patient list search bar. And then after that, all the data presentation, as a reminder, is identical for patients and providers. So as a clinician out there, those of you watching this archive, keep in mind, whenever you're looking at the data, you're talking to your patients about that data. It's the exact same thing when your patient's logging at home. It's pretty great. So I'm going to highlight a couple of key things throughout the different views within Tidepool, and then we're going to focus on Dr. DeSalvo and his years of experience and understanding what this data means. So with our basics view, we are providing an overview of all the data that's been uploaded to a given Tidepool account. Specific for Control-IQ, for those of you out there, shout out to Tandem. We are providing a couple of specific highlights in terms of the data presentation that is relevant to Control-IQ directly. There is an automated correction bolus feature specific to Control-IQ. You can identify how many of those boluses have taken place within a given reporting window within the basics view by checking out the bolusing section and clicking this automated filter here. So now you can see there were 150 boluses that were automatically initiated by Control-IQ during this 30-day time period. During that same 30-day window, I gave myself 127 boluses. I know that by clicking on this filter over here. 127 by me, 150 by the machine. It's kind of humbling when you think about how often this thing is actually doing work to try and keep me in range. On the right side of the basics view, you will see your summary stats to show off your time in range for your reporting window. Green is goal throughout the Tidepool experience. So you'll be looking at my target range, which is set to 70 to 180. On average per day, I'm spending about 70% of my time in range. Not bad. Obvious opportunity for improvement there, but I will take it. Holidays weird. Average blood glucose based off of CGM data, such as usage percentage, your basal and bolus insulin ratio. That's always a key thing to keep an eye on there, as well as your average daily insulin use. And then specific for Control-IQ, you're seeing the time spent in automation. Most of my time is spent in automation, except for whenever I'm changing my site, obviously, or in case I am sleeping on my pump and it loses connectivity with my CGM for more than 15 minutes. And then lastly, again, specific for Control-IQ, we have time spent in sleep and exercise activity. For those of you that are using the Control-IQ pump, the Tandem pump with Control-IQ technology, you'll know that you have the ability to set those different activity settings, and that will adjust how the algorithm and the pump are going to function there. The last number I'll highlight in the basics view is GMI. This stands for Glucose Management Indicator. I'm not sure how many of you are going back into your endocrinologist office for your appointments or your blood draws, but this is an approximation of A1C based off of your CGM data. So between this and my time in range, I get a pretty good idea of how I'm doing just by looking at my data at home. This obviously is not going to replace the blood test, but again, something to keep in mind there. Two other quick things here. The trends view is going to be showing off your CGM data over the course of a 1, 2, or 4 week period. James Jellyfish here has some opportunities for improvement based on the last 2 weeks, as you can see, with these breakfast bolusing and whatever is happening post lunch. I can tell you, because I am James Jellyfish, that I just don't eat lunch at a regular time. So it's a whole thing. We can get into that later. But again, you'll see this time and automation widget and our time and activity calculations are also returning into the trends view. So you can see over this now 4 week period. Ready? Wait for it. Wait for it. There we go. This 4-week period, how much time is spent using the sleep and exercise activity, as well as our time in range calculations, in range, above range, well above range, below range, and well below range over here. The last thing we'll highlight, and then we'll hand it over to Dr. DeSalvo, is our daily view. Here's where we're going to spend the majority of our time during this webinar. Here we're looking at, again, control IQ data, but because Tidepool standardizes all the output, no matter what you're uploading, it's always going to look like this. Tandem, Medtronic, Omnipod, we're good to go. This is what data looks like in Tidepool. CGM and blood glucose readings will show up in this top bar. Your boluses and carbs will show up in the middle section here. You can hover over any of these because we're on the internet. We can hover over stuff and show you more details. It's pretty great. So here's a standard bolus for breakfast. You can see carbs entered, amount of insulin delivered, insulin pump settings. Those automatic boluses I was telling you about earlier, there's 150 over the past 30 days. They show up in a darker bolus bar. You can hover over that to see the automated bolus, as well as the amount of insulin delivered and the time delivered there. And then in our basal section, we have our basal delivery over the course of these segments based on what has been programmed in. Any increase or decrease can very clearly be seen. Here's an increase, here's a decrease. And then anytime I'm using exercise or sleep activity, we have the E and Z flags here, E for exercise, Z for sleep, to show off when we're using, again, that specific functionality. Things are displayed slightly differently for the 670 or for basal IQ. We can get into that if we so desire. But again, broadly speaking, this is what everybody's going to be looking at when they're logging into a Tidepool account. So, Dr. DeSalvo, I'm going to take a breath and a sip of my Diet Coke. Where would you like to begin your analysis and walking through some of your process on how you interpret this data and how you collaborate with your patients on providing quality care?
Yeah, so first of all, that was like an amazing, really quick overview that I think.
Can you tell I do this often?
Yeah, and super actionable for clinicians, but also for parents and people living with diabetes. We're focused on a pediatric case study here. And so I'm going to fictionalize James Jellyfish to be a 17-year-old. He's a senior in high school, has a goal of going to college next year. He loves to play soccer. He's also in the marching band. He's a super active young man. He has a lot of friends. He lives a busy, active life. I mean, it sounds familiar probably for any parents or young people with diabetes out there. And so I like to start with kind of the big picture view and then hone in on the daily view from there. So if you look at the basics tab, Christopher went over this nicely, but it's a good kind of snapshot, and you can get a sense of how often James Jellyfish is bolusing here. He's pretty engaged with his diabetes. Diabetes is a journey. And there can be periods where you're dealing with diabetes distress or burnout, or there's just a lot of things on the plate. And remembering to bolus, or just getting to a place where you just don't feel like managing diabetes, you may not see as many boluses here. And so it's a good opportunity not to do shame and blame, but just to try to hone in on, if there are areas to bolus more often, try to understand what the reasons for not bolusing might be, and to come up together with strategies to try to increase those opportunities to bolus. And as Christopher pointed out, with Control IQ, you've got those automatic boluses in the background, so that if the user forgets the bolus, control automatic boluses are there to kind of pick you up a little bit. And just as a brief mention of that, the way that the auto correction boluses in Control IQ work is that if it's been an hour since the last bolus and you're predicted to go above 180 in the next 30 minutes, it will give a bolus 60% of what it would normally give based on your correction factor to get you down to 110. And so as he pointed out, there have been a lot of auto correction boluses that have been given by the system to help keep the time in range. So a nice big picture here. I do want to point out to the clinicians here, one of the features that I love about Tidepool is just how user-friendly it is. But if you look at on the right side where you've got the CGM glucose metrics, you see that copy as text right above? Literally, you can click on that. And then, Christopher, you want to, you can even pull it up on a Word document or something to show the audience. But you can copy that and then paste it into, in my case, the electronic medical record. And it captures all these really crucial CGM metrics and also the insulin data and everything else that you can place right into your note. So it's really simple, easy. There you go. You've got it all right there. So you don't have to free text. You can just copy and paste a really nice feature of this. So let's look at that as it relates to James Jellyfish. And let's actually go ahead and toggle over to the Trends tab. Let's first of all acknowledge the incredible job that James is doing right now with his diabetes management. Very engaged, staying on top of things, and that's why he's living a busy, active life. CGM metrics, CGM glucose metrics, the ambulatory glucose profile, there are some goals that are based on international consensus guidelines, and it helps to know what those are, but they must be individualized based on, the stage in that person's diabetes journey. So here we can see that they have really close to 70% time in range. If we look at that average daily time in range, again, it's that green bar. That's the percent of values between 70 to 180. So right at that goal of 70%, which is kind of anchored to a hemoglobin A1C that's around 7%. We get that from the GMI down below, the glucose management indicator. For James Jellyfish, he's right at that goal of less than 7%. He's right near it there. And so we have to, acknowledge the amazing job that he's doing. We also see that he has pretty minimal time below range. As clinicians, we talk about level 1 time below range, which is the percent of values less than 70 to 54 milligrams per deciliter. He has just 0.4%. And the goal is to have less than 4%. So, he has really minimal time in range, time below range rather. And then level 2 time below range, which is the percent below 54, which is the dark red there, only 0.1%. And the goal is less than 1%. So he's got pretty high time in range, really minimal time below range. So what we probably need to target here is that time above range, the time above 180 and the time above 250, which is also shown on these time in range bars here. So if we hover over to the left side, we can kind of see some areas where we can target that time above range. So the green and purple squares there are the median glucose values by time of day. And I actually like to, Christopher, if you can unclick the 100% of readings down below, this I think kind of hones in a little bit further, where you have the 10th and 90th percentiles on the bottom and top of those bars there. You can see that after breakfast, after lunch, and then kind of late evening is where those purple bars, which are above 180, the median glucose value, the average glucose value, the 50th percentile, is above 180. So we can kind of see that pattern to where overnight from midnight to the morning, look how nicely that glucose is kind of coming down into range. It's really kind of narrow, so not a lot of glycemic variability there on average. And then some sort of spikes after meals that we can probably target here a little bit. So this kind of helps you look at the big picture view. And then in a second, we're going to go over to that daily view to kind of hone in on what's happening on a day-to-day basis. But looking again on the right side here, we've got that average glucose. He already went over this, but the automation piece, what's nice about Control IQ is that as long as you have an active sensor, you're going to be in automated mode. Unlike 670G, where sometimes it's ushering you out of auto mode if you are not calibrating, or if you are at a certain level of insulin delivery, it might usher you out of auto mode for a while. With Control IQ, here we can see is 99% of the time in auto mode with Control IQ, and doing a nice job also of using sleep mode as well as exercise mode, which is shown right below that. So we'll see it on a daily view, but he has a sleep profile that's scheduled, and I always, as a clinician, I'm looking at, are we getting the full use of that sleep profile? And I'll talk a little bit about what sleep mode is, what the target is for Control IQ, and where in James Jellyfish's case, I'm probably going to maybe change what his sleep profile is to optimize his time in range. And then that GMI again is that sort of estimated A1C, or glucose management indicator, and so he's right there. And his CV, coefficient of variation, that shows how much variation is there around the mean, and the goal is for that to be less than about 36%, and he's there, 33%. So overall, has glucose control that is going well for him, but we're going to look on making some fine-tune adjustments to improve it, and really highlighting the incredible work that James is doing with his diabetes management.
There's a question in here, and real quick, so a reminder, everybody to watching, if you do have questions as we're going through all this, you can use the Q&A button at the bottom of your Zoom window here. As you're assessing this, I mean, part of assessing the data is also assessing like the patient, where they are in their lives, and especially when it comes to like pediatrics, like where they are in puberty, like what their high school routine is like and things like that. But how do you begin to identify how many areas of opportunity or how many action plans you want to put into place? Because like, as you can see, like within this like 2-week window of the trends view, there appear to be 2 or 3 like very clear actionable like things to change just based off of like where you're seeing those spikes. But how do you go about evaluating like how many things to actually like sort of task to the patient or the patient's family, given like, again, the holistic reality of their lives and whether they can handle making 4 adjustments versus 2 versus 3 or something like that?
Yeah, it's a great question, Christopher. And part of it is understanding sort of what their goals are And also in James Jellyfish's case, I mentioned that he plays soccer, he's in marching band, and understanding what times of day those are. So like, let's say, for example, that he has soccer practice in the morning. Well, maybe the reason why that glucose is a little bit higher in the morning is because he wants to have a little bit higher, safer glucose value in the context of exercise. So that's, that's one example, is understanding what their activity profiles are, what time of day they have planned activity. Now, in the case, and we'll get to Bonnie Blowfish next, who's a young child with diabetes. They have a lot of spontaneous play. So it's not quite as predictable, where maybe they're just playing on the playground with friends and things like that. So it's a little bit different from someone who's in high school that has planned activity. And then it also comes back to, maybe, let's say that James, for example, wasn't bolusing often, and is going through, whether it's either forgetting, or maybe he's at a place where he doesn't feel comfortable bolusing in front of his peers at the lunch table. Thinking through strategies, not necessarily about adjusting his doses, but thinking through, how can we give him the confidence? How can we, do it in a way that if he's at a place right now that he wants to be discreet about it, he can do that. And thinking through, what are the strategies together, because I'm not going to be able to think about it for him. What are his ideas to where he can get those boluses in? And so you're right. Like, diabetes is not as simple as carbs in, insulin out. It affects the glucose values. I love the poster from Adam Brown when he was with Diatribe Foundation. That's the 42 factors that affect blood glucose. And I think that's just the tip of the iceberg, right? It's not even just 42. It's that's just the tip of the iceberg. There's so many more than that. So understanding that it's not just the insulin doses, it's not just the bolus settings and basal settings, but it's about putting all of that together. But then part of it also is about understanding, like, what are your goals in diabetes right now, right? Like, for me as a clinician, maybe my goal is to have your A1C less than 7%, your time in range above 70%. But maybe for you right now, it's more about, it's not really about the numbers, but it's about, how can I actually, improve my soccer skills right now and be more in range when I'm playing soccer, so that I can, be better on the soccer field and a better teammate, wherever the case may be. So understanding not just what their sort of CGM or A1C goals are, but what are your life goals? What is it that you're wanting to do? And then tailoring any adjustments for that. Getting a sense of where they are in their diabetes journey with that diabetes, stress, and burnout that we talked about. And maybe our conversation in a clinic visit is less about data and more about, how are you feeling about diabetes right now? What's going really well for you? Because trying to find those sources of strengths and what's going well, I think, is really helpful. Then also, what are the pain points? What are the pieces you're struggling with? And we're really fortunate to have social workers that can kind of help with talking about the non-medical side of diabetes, helping with resources. And for me as a clinician, really pouring into that person and helping them tap into those strengths that they have, and targeting any areas where they need a little bit of additional support.
Thank you. I find it interesting that, as we're going to continue to talk about you assessing the data, that there's that you have to continually be mindful of all the other factors, not just diabetes related, but again, taking the human approach to diabetes care. I don't know if I necessarily have a question about that, but I guess I just wonder where the opportunities are on the caregiver side to be an active participant in that discussion. Like, obviously you're seeing the data, you have questions that are going to inform the decisions you make in the conversation you're going to have, but are there any recommendations that you can offer up sort of broadly to caregivers in advance of those appointments, as they're trying to think about how to best collaborate with their child as it relates to diabetes management?
Yeah, for sure. And that's an important point also, because, for us in pediatrics, it's really about the whole family. And beyond that, it's about the village of the person who's in the life of that person with diabetes. Mm-hmm. So, for example, as the caregiver, it really depends on their stage. And so, in the case of James Jellyfish, he's a senior in college. And so the conversation that you're thinking about is how can we get James empowered to the point that he's ready to go off to college next year? What does that look like for me as his mom or dad or his caregiver? And how can we have a conversation around that? As an example, maybe it's dealing with how the share feature, in this case, he's on Control-IQ. So we'll talk about the share feature of Dexcom. It might be that right now you have it set up to where every time James gets a low glucose that's below 70, you get a notification on your side and you're texting him or calling him. Maybe you think about, why don't I lower that down to 60 to give James a chance to respond? And let's think about also, maybe it's not just me as his parent, but Does he have a friend that we can maybe delegate some of that responsibility to at school, and be thinking about when he goes off to college? Is it a roommate? Is it a friend? Is it somebody else? What about when James is playing soccer and a marching band? Who are the people that he can talk to about diabetes so they can be there to help him when the time comes in? To your question, Christopher, about how to kind of prepare for a clinic visit, be prepared to think about what are your goals for that visit? What are the things that you want to discuss? And in the case of James, let's deputize him to be kind of in the driver's seat for that conversation. As a caregiver, whether James is 17 or 18 or 25, 30, or even 40 in my case, and I forgot to mention in my bio, I have type 1 diabetes as well. That's what really ignited this passion for me to become a pediatric endocrinologist. And I love every day I get to do this. So here I am, 40 years old, and my mom is still one of my sources of support. A lot of that's been shifted over to my wife, who helps me every day, but my mom still kind of checks in and makes sure everything is going well. So as a caregiver, shifting that independence and getting to a place where James, I see he's getting older, is in the driver's seat with those conversations. And maybe one time before he goes off to college, he gets to practice doing that appointment kind of on his own, so that he can be ready to do an endocrine visit when he goes off to college next year. So think through, for you as a caregiver with your son or daughter, what are your goals for that visit, both as it relates to your diabetes management, but also life with diabetes, life on the road, things like that. So be prepared, and that always helps to kind of anchor the visit.
Okay. Peter, I see your question in the chat. We will get to that in a little bit. Let's dive back into the data. After the trends view, where do you go next?
So I really like to look at the daily view next. And so the daily view, a couple of options here. And Christopher kind of showed it on this Tidepool web portal, where you can kind of look at it. You can just sort of go back over time. For me as a clinician, I like to pull up the PDF. So if you can pull that up, what I like about the PDF is that you can look at multiple days here, and kind of look at those patterns, and then look at those opportunities for some adjustments to his doses. So, one thing I start with is looking at what's happening overnight. And we got this from the trends view, but here on the daily view, you can also see, look at how the glucose is sort of humming along. And you can see control IQ with the basal rate modulation right below the glucose. So you can see he's mostly in the green zone, so to speak, with glucose values from midnight to when he wakes up in the morning. There's that basal rate modulation that's working well for James jellyfish. So it looks like his basal rates overnight are pretty spot on there. One thing that I notice is that he tends to kind of, and you can kind of appreciate this, but if you look at sort of 6 a.m. to 9 a.m., he's starting to rise just a little bit before that. I also noticed that his sleep mode, if you look at that Z, is ending somewhere around 7 a.m. So even if James is waking up at 7 a.m., one thing that I'm noticing right away is that we could probably extend that sleep mode out a little bit further. And what I like to do as a clinician is actually lengthen that sleep mode out until about an hour after the first bolus. And the reason for that is that with sleep mode, control IQ normally, if it's not in sleep mode, is aiming for a glucose value between 112.5 to 160 milligrams per deciliter. And then in sleep mode, it's kind of anchoring that down to 112.5 to 120. It's not giving any autocorrection boluses, but it's able to kind of modulate the basal to keep the glucose level a little bit in a narrower target range. And so I think in James's case, we can extend that sleep mode out to about probably around 9 or 10. I would ask James, what time are you bolusing each day? And I would extend that sleep mode out to about an hour after he eats breakfast. And after that, sleep mode goes off and the auto boluses come back on. So that's one thing I would probably do for him. The other thing I would
have a question / caveat to this. This is going to be kind of dicey, but what if James, or raise my eyebrows there, James were exercising immediately after waking up or sometime after waking up before breakfast? So there's sleep activity, there's a morning routine, there's exercise, then there's breakfast. How does that, if that were the more traditional routine for James, how might your recommendation, your consideration of extending the sleep mode functionality, sleep activity functionality, factor into how you would approach that?
Sure. And James is already doing this really well, right? Because you can see where James is using an exercise mode for his morning soccer practice. So I would advise him to do exactly what he's doing, which is at least 30 minutes to an hour ahead of that activity, turning on that exercise mode. So what that looks like in control on the t:slim X2 pump is that you would just go into that activity profile, you would turn sleep off, turn exercise mode on, and then you would go into your activity. So for the days where he's not exercising in the morning, that sleep mode would be extended. But on those days where he is exercising, he would activate exercise mode, which, by the way, bumps up that target range to 140 to 160 milligrams per deciliter. So I would still probably extend sleep mode, but still encourage James to activate, turn off sleep mode on the mornings where he's waking up to exercise, turn sleep mode off and start that exercise mode early. If it was every day, we probably wouldn't extend sleep mode out that far.
Okay, cool. All right, yeah. So I guess here's another, I guess, highly specific question based off the data that we're looking at. How much stock do you put in holiday activity? Because here we see Thanksgiving and the Thanksgiving sort of window, and nothing is normal about the holidays, especially eating habits. Not especially. Eating habits tend to be slightly more irregular. Let me be more precise about that. Tend to be slightly more irregular around the holidays more often than not. And that can create challenges for a variety of reasons. When it comes to those sort of more typical irregularities as it relates to diabetes data, because of things like changing of eating habits, changing of sleep patterns because of holiday travel, things like that. How much stock do you put into that when it comes to evaluating the data and discussing changes and recommendations with your patients?
It's a good point. And that's why having a dynamic diabetes management approach is so important. And think, like weekdays are different from weekends. Holidays are different from school days, are different from summer days. And so, one of the advantages of Control-IQ, of t:slim X2 pump is that you can have different profiles on that pump. So depending on what the glucose values are, what the insulin needs are, you might actually create a separate profile for the holidays or for summer versus school. You just have to remember to flex those back on and off. Mm-hmm. So on those holidays where you are sleeping in a lot more, you might think about extending that sleep mode even a little bit longer. If you're eating a lot more and you're noticing that you're running higher, you might need to flex up your basal or your bolus settings a little bit to account for less activity and more kind of the sedentary lifestyle that the holidays bring with a lot of eating and things like that. So definitely important to think about not just where you are and where you've been, because we're looking at the retrospective data here, but think about how does this fit in with what next week, the week after that is going to look like as well.
Okay.
Go ahead.
No, you're good. You're good. I'm enjoying the ride right here. This is a lot of fun.
And you're bringing on like these really practical questions that are like, this is life with diabetes, right? Like this is just life with diabetes, that every day is different. Like we're living these vibrant lives, and it really goes back to, it's one thing to look at the data, but it's also important to incorporate the person, the family, and what their goals are. A couple of really quick hits with James's data is that we do see, if you scroll up a little bit, and we saw this on the trend view, is that he tends to have, that postprandial spike with breakfast. And almost always we're having to get some correction boluses, whether that's the auto correction boluses, which have the box around them, or some manual boluses entered by the user to get him back down to range. So I would tighten his carb ratio at breakfast. So I have reviewed his settings, and right now his carb ratio at breakfast is a 9 or a 10, and I would probably tighten that. Yeah, you can see if he's eating breakfast before 8 a.m., it's a carb ratio of 10. If he's eating breakfast after 8 a.m., it's a carb ratio of 9. I would probably tighten that carb ratio down to 8.5, which you can do on Control-IQ on t:slim X2, or 8. Try to understand from James, again, what is the activity level after breakfast? If there's no activity, I'd probably go to as tight as an 8 on his carb ratio. If he is exercising or has PE or recess or something, we might just start out with more like 8.5 or so. As you get into those really tight carb ratios, a small difference, even an increment of 0.5 or so, has an exponential impact on how much insulin it's giving. If we're making a change of a carb ratio of 20 to 19, it's barely going to touch the total amount. But if you're making a change of 9 to 8 or 8 to 8.5, it's going to provide some extra insulin to that bolus.
Question about settings changes, and I think the Tidepool, the broader web view might be helpful here. For that settings change or for anything else like that, how much data do you feel is necessary to assess whether the change is you have enough information to assess the sort of value or impact of the change? Because obviously, if you're making a change that is specific to weekends, you need weekend data to inform whether or not that's working. So that's going to sort of extend out your sort of waiting period for data collection there. But if it were a change, during breakfast time during the week, how long do you wait before you say, okay, this isn't working, or hey, yeah, this is working, let's move on to some other opportunity?
So a couple things on that. One is I like to look at least the last 2 weeks of data or 30 days to be able to really have enough data to have an informed decision. And then looking at how that's working going forward, I counsel families, one day does not a pattern make. If it's been, if it's been a few days where you're seeing a clear pattern of running higher or lower, either the family can make the change, they feel comfortable with it, or they can, talk with our diabetes care team to make some adjustments from there. So as an example, over a 5-day period, if you have, 3+ days where you're seeing that pattern happen, you can start to kind of hone in on making those changes. So retrospectively, at least the last 2 weeks going forward, looking at the next 4 to, the next 5 to 7 days or so, if you see a pattern with running lows or highs, that's probably enough time to make a change. It's a nice feature here in this trend view, where speaking to the weekdays and weekends, where you can click on, to just look at weekdays or weekends and kind of try to understand what is the difference, so that you can talk about diabetes management. Maybe it's that, on the weekends, think about, you may not make a change in the pump where you're flexing on and off a certain pattern, but you might be able to give a little bit extra insulin for breakfast or lunch on a weekend where maybe they don't have that PE or exercise compared to a weekday.
Right on. So I think this is actually kind of relevant now. I'm going to bring this in from the chat. Thank you, Peter. Our daughter has a breakfast spike every morning, and before lunch, and before lunch is going hypo. Her basal for the morning is as low as it can go. What can she do to avoid this low before lunch, where having a crazy carby snack may not be possible? So again, this is factoring a number of things in terms of the setting, physical activity, and sort of the day-to-day operation there. And then you also have to factor in opportunity for, access to corrective, low treating snacks and things like that. But as you're assessing that sort of a trend, if it is consistent enough, where do you begin to assess opportunities for adjustment there?
Yep. So there's 2 pieces of that. One is he said that his I think daughter is having that post-meal spike with breakfast, and on the back end of that, she's drifting down going into lunch. So first of all, targeting that post-meal spike, I always tell families there's 4 ways to minimize that post-meal spike. You can tighten the carb ratio to give more insulin for the bolus. In her case, probably can't do that because she's going low on the back end of that 3 to 4 hours later. Secondly, you can work on pre-meal bolusing, giving that bolus a good 10, 20 to 30 minutes early, or talking to your healthcare provider about options like Fiasp or Lyumjev, faster acting versions of Novolog and Humalog respectively. Thirdly, reducing either the carb content, or the how fast those carbs are. So either reducing the total amount of carbs or using lower glycemic index carbs. Things like, instead of doing the traditional cereals, using something like a keto cereal, which the goal is not to be keto, but to use a lower glycemic index carbs, or incorporating fat and protein into that breakfast. So those are different areas that you can target reducing that post-meal spike. On the other hand, going into that low, if you can reduce the total bolus by reducing the total carbs or using lower glycemic index carbs, then you might get to a place where you can actually reduce that low going into lunchtime. Depending on what system his child is on, if they're on a closed loop system, you might be able to raise the glucose target. If they're on a system like Loop, raise that correction range to where it's a little bit higher going into lunch, which can minimize the basal rate modulation to reduce the risk of a low going into lunch. So without knowing all the details of that child's system, it's hard to say exactly, but you can try to target that breakfast, maybe even reducing the bolus a little bit, which will reduce that back end. And then thinking through what is her target, what is her correction factor prior to lunch to minimize the insulin that she's getting to reduce the low going into that time.
Cool. Thank you. Thank you again for that question, Peter. All right. Anything else on James before we hop over to Bonnie? Yeah,
just one quick thing on James that I want to note, and wearing my provider lens, if you pull up that PDF report, one of the things that I noticed is that from, that time where he's running a little bit higher from around noon to, where he tends to run a little bit higher in the afternoon period. And James's lunch is kind of varying every day, so eating at different times. Again, I noticed that there's a few correction boluses to bring it back down, whether that's auto correction boluses or manual. He has a softer correction factor in the afternoon. It's 50 versus 40 in the morning and the evening. I would tighten that correction factor from noon to around 8, from 50 down to 45 or even 40, to give a little bit more bang for the buck, to get him down a little bit sooner into range. So, and then finally, we see that he tends to rise a little bit later at night. I'd probably go up a little bit on his basal rate from around 8 p.m. to midnight, which is that time where he tends to rise. That rise starts around 9 for James. When I make a change to a basal rate, I try to do it at least 30 minutes to an hour before the glucose is either rising or falling. So in this case, since it's rising, I would raise that basal rate a little bit prior to that 9 p.m. time. So at 8 p.m., raise his current basal rate of about 0.65 up to 0.7 to get in front of that a little bit. So taken together, we've increased his doses by a little bit. We've tightened his carb ratio at breakfast. We have kind of tightened his correction factor, sensitivity factor in that afternoon time. And then we've gone up a little bit on his basal rate for that evening with what I call the dusk phenomenon, where we see this sort of delayed rise after, either after he's gone to sleep or after he's eaten dinner.
I have some feedback for James Jellyfish's activities that may influence some of his recommendations, but I really appreciate, James, appreciate you taking a look at this data. Let's switch over to Bonnie. Is that right, Bonnie?
Yeah, so Bonnie Blowfish, while you're pulling this up, she is a 4-year-old girl just diagnosed with diabetes a little bit less than a year ago. She has amazing support from her awesome parents. She is in daycare where, they're taking good care of her. Sorry, she's in preschool now. They're taking good care of her. They don't have a school nurse there. So it requires a lot of communication between the mom and the daycare teachers or daycare instructor, but they're doing a really good job. Mom, the parents are concerned because it seems like she's just requiring a little bit more insulin. She's getting further away from diagnosis. She's kind of exiting that honeymoon period or partial remission. And they feel like she might need a little bit of a tweak to her insulin needs. And so again, looking at her, a lot of work that's being done here, good boluses, multiple times a day, a lot of effort. If we look at her trend profile here, again, we can see that she's super steady overnight. She's waking up really tightly in range in the morning. Not a lot of hypo here either, only 1% below 70, 0.2% below 54. Time in range is at 63%. The average glucose is 165 with a GMI. It's going to be right around probably 7.3%. So again, an opportunity. What mom says here is kind of spot on. Maybe it's a little bit of a tweak in her insulin here. And we can see some areas where, this is so common in diabetes, but that pretty impressive post-meal spike at breakfast that we can target, and kind of, a little bit of a rise in the afternoon, and that dusk phenomenon where from after 9 or so, she's kind of having that delayed rise up. So some areas to kind of hone in on there. Looking at her daily view, which we can also pull up the same way that we did for James, looking out on the web portal. Again, I like to look at this. We can kind of hone in here. So
we should mention before we dig into this that Bonnie is currently using DIY loop in the Autobolus branch. So all the caveats included there around the use of an off-label system that we are, just want to make sure that that's clear in terms of the data that we're looking at.
Yeah, that's a really good point. So a lot of information here with all those autoboluses that are given by that DIY loop system. We can see the basal rate modulation down below, her CGM glucose values. And I had also reviewed her settings. And I noticed something about her settings, which is that for her carb ratio, right now, from 6:30 a.m. to 8 o'clock a.m., she has a really tight carb ratio of 7. But then at 8 a.m., it backs off all the way to 15. And I think the intention for that is that she would have a little bit higher bolus for breakfast. But when I look at this, I'm noticing that, fortunately, her mom has a pretty flexible work schedule, working mostly from home, and she's been dropping off. She's allowed Bonnie to sleep in a little bit, and she's not actually eating until around, as you can see here, until after 9 every day. So her breakfast bolus is actually it's actually with that carb ratio of 15 that changes at 8:15 a.m. So she's not getting that breakfast bolus carb ratio of 7 because of just the timing of when her bolus settings are. So, the first thing I would say here is we probably needed to tighten the carb ratio at breakfast from 15, probably not all the way down to 7, which would more than double her breakfast bolus, but let's maybe tighten it from a 15 to like a 12 or even a 10 to give her a little bit more bang for the buck with that breakfast bolus and reduce that post-meal spike at breakfast. So I would change her pump settings. I would change her bolus settings with her carb ratio. One, by extending that period of 6:30 a.m. to 8:15 all the way out to probably like 10 or so, and changing the carb ratio to 10 or 12, which is going to give her a bigger breakfast bolus and really dampen that post-meal spike at breakfast. So the lesson there is pay attention to what your bolus settings are. Make sure that it makes sense, that it's anchored to the time of day that your child normally eats, and that they're getting whatever that dose is intended to be. So that's kind of step number one, and that I think that's really going to help out a lot, because what's happening right now with Bonnie is that she's running pretty high after breakfast, and on a lot of days it just never catches up. She kind of stays high. There's kind of multiple auto boluses that are given, but she just doesn't quite come all the way down. To help out with that, I would also tighten her correction factor, which right now for her is around 250 or 300, which is probably related to when she was in honeymoon. It's a pretty soft correction factor for her. Her total daily insulin right now is around 13 units per day. And as clinicians, we use something called the rule of 1800. 1800 divided by 13 comes up with an estimate of what her correction factor should be. And that comes out to like around 1800 divided by 13 is like around 140 or so. So I wouldn't go all the way from 250 or 270 where she is now, but I would tighten her correction factor down to probably something like 200 or 200 or so, depending on what the family's comfort level is. That's going to help to get her down a little bit sooner, both with the auto correction boluses that are given or any boluses that are given by the family with this loop system. So I would make those two changes for her, tightening that carb ratio for breakfast, but also tightening up that correction factor, sensitivity factor. The final thing I would consider in a system like Loop is what is their correction range, which is the target that the system is aiming for, and thinking through what are your goals, what are you comfortable with, and trying to match that correction range to what the family's goals, their comfort levels are. And usually it's something in the range of about 100 to 140 or so.
All right,
So I have to Bonnie's breakfast is there's a breakfast, and then that 9 a.m. is a school snack, the one that's after the 8:15 timing. So there's just that. There's a lot of food in the morning.
Yeah, the challenges and opportunities of a young child with diabetes, right? Where they tend to, exactly as Cyrus said, it's not just breakfast, lunch, and dinner. There's some snacking that's going on through the day. There's the spontaneous play. There's the moods. It's all this stuff that goes into a toddler or a preschooler with diabetes that can make the management so hard. So I always pause with that and say that parents of kids with diabetes are my heroes. And what you do on a day in, day out basis is amazing. And having that village around them to support them is so key. And so, yeah, that's one of the challenges here, right? So you got to make sure that with those carb ratios, it might be a little bit tighter for breakfast, but for that snack at school, making sure we're backing off of that carb ratio a little bit, because maybe she has recess right after that. So it's a really important thing. It comes back to our previous discussion about James, understanding what does their day in, day out patterns look like, and how can we fit their diabetes management to kind of fit with that schedule.
As we are closing out this webinar, Real Life solar panel installation company has shown up to finish their installation, even though they said they were coming in the afternoon. So we're going to run through the last of this a bit abruptly. I apologize, everybody. Questions in from the chat. Magnus, how would time and target look if you change the target? Good news is that any Tidepool user can adjust their high and low blood glucose targets. We will recalculate the time in range based off of those high and low thresholds, and then we will adjust the time above and below again, based off of that initial setting. So every patient has the ability to set that themselves. And then the clinician would see the exact same representation of that blood glucose target whenever they're logging in to view that data. Thank you for the question, Magnus. Question in from Mary. Any idea when FDA approval for Loop will be for either Tidepool or Omnipod? For Tidepool, stay tuned. As soon as we hear something, you'll hear something, because we will tell everybody. We'll shout it from the mountaintop. I'll be sending out that email. As far as Insulet is concerned, I'm sure they're eagerly anticipating news from the FDA as well. Stay tuned. Again, it's my experience in all these things is that, one, times are still not normal, and the FDA is doing what they can to address non-COVID things and COVID things, but COVID things are still massive. So they're doing everything they can there. And then also, whenever these companies have something to say, they will say it, because they want this technology to be available, because we're all working towards improving the lives of people with diabetes, top to bottom. One last question from Magnus. This is a little bit off topic, but since you brought it up, Dr. Dan, excuse me, you mentioned Lumijev and how much faster it is compared to NovaRapid and Fiasp. Is it approved for children? Any comment there around sort of the availability of that more rapid insulin for the kiddos out there?
So 2 things on that. One is I tell families, it basically shifts the curve left by about 10 to 15 minutes. It still peaks at 1 to 2 hours and lasts for about 3 to 4. So the practical takeaway for that is it's still probably important to pre-bolus, especially if you're a little bit higher going to the meal, or if you're eating a meal that has, is either high in carbs or has fast carbs. So bolusing with Fiasp or Lumijev right as you're about to eat is equivalent to bolusing with Humalog or Novolog 10 to 15 minutes early. So that's kind of the practical takeaway. It is now approved for use in insulin pumps, but not necessarily with closed loop. It's not approved for use in closed loop systems. That's why it's really important for any of this to make sure you're talking with your specific diabetes provider to see whether or not some of those options might be things that could be useful for you or your child.
Cool. One last question that came in from Magnus. When will we get a Tidepool server in Europe? Not sure, but also for what it's worth, Tidepool software is not region restricted. So you are welcome to go to, this is actually a fantastic segue, which you didn't even know about. You're welcome to go to tidepool.org/sign up and get your Tidepool account created today. Again, not region restricted. Have a go there. When in doubt, if you have any questions about use of Tidepool software, you can contact support@tidepool.org. I'm still really impressed with that segue that I just did there. I'm sorry, y'all. And one last thing, again, we are a nonprofit donation. Donations are always welcome at tidepool.org/donate. And if you're feeling extra spicy, you can click this little tab here to make this donation recurring. We appreciate any and all donations in support of our nonprofit mission to support people with diabetes and make this stuff more accessible, meaningful, and actionable. This has been our pediatric case study with Dr. Dan DeSalvo. Again, still really impressed at that segue. And because I'm talking about the segue, I've ruined it. Dr. DeSalvo, thank you for spending the past hour of your day with us, sharing some of your knowledge and insights with all of us. I appreciate it. I know James, wink, appreciates it. Bonnie also appreciates it. Everybody watching live and everybody watching the archive as well. So thank you again. Happy holidays. Any closing thoughts, Dr. DeSalvo? I'll give you the last word.
No, just thank you again, Christopher and Syra, for this invitation and to be able to share with this platform, and to the Tidepool community out there. It's amazing what you guys are doing. And even things like the data donation, and for the work that Tidepool's doing in this space with building this community, and also just caring about people with diabetes. It means everything. So thank you for allowing me to partner with you guys today. Really appreciate it. And
for sure.
Happy holidays to everybody.
Yeah, I didn't ask him to give that final Tidepool plug, I swear. All right, everybody, that's been it for Tidepool's webinar. Stay tuned for additional chats with us probably in the next year, because I'm not going to be hosting any more of these, because we've got a lot to talk about for the remainder of 2021. And thankfully, 2022 is right around the corner. Stay safe, everybody. Take care.